from now over the next 120-ish slides, okay, from that standpoint, it's just we're going to hit through key topics and all that stuff. Again, if you could understand that first part of the lecture, I mean, the first third of this is really the ideal place of where you understand, okay? Because if you can get all of that, the rest of this makes sense. Okay. So, our different types, okay? Heart failure, coronary artery disease, valve disease, aneurysms, okay? Arrhythmias, which we'll talk about, cardiomyopathies, we won't so much, and pericarditis, not so much, okay? We'll touch a little bit with the cardiomyopathies when we talk about heart failures and all that stuff. Okay? But what do we see predominantly? Okay? When someone calls 911, hey, 911, what's your emergency? Okay? What are they calling for? Angina, okay? That's the number one complaint, okay? Pain. From that standpoint. Okay? From there, behind that, shortness of breath and all that stuff with the heart failures. So coronary disease, okay, getting into a complex, all it is just simply is you get a building up, okay, of the inside, okay? And the veins and all that stuff, what's the inner layer of the veins and arteries called? The tunica interna, good. The middle portion is the tunica media, and the outside is the tunica externa. Good. Okay. All right. Risk factors, all that stuff that have a, okay. Unfortunately, these are things that just can't take care of. I'm sorry. I can't change the aspect that I'm a male. Okay. I can't change the aspect that I'm in my mid-50s now. Okay. Can't do that. It's there. Okay. My aspect of if I do have high blood pressures, I can affect it, but I still don't have anything. Okay. Some people from there, you can affect obesity, you can affect exercise, cholesterol to a point, and of course, the number one risk factor is smoking. Okay, so if you're smoking or a vapor, stop. Okay, it's the worst thing that you can do. Okay, ACS, acute coronary. Okay, cardiac compromise from that standpoint, it's when the heart kind of sort of gets blocked. I mean, there's different reasons for it. It could be coronary spasms versus a drug problem versus an embolus, so there's a whole bunch of different factors. Okay, ultimately, you can go from the ischemic to the infarcted state. The ischemic is it's not getting enough, it's still alive. I can reverse that. I can take care of that. Versus the infarctic side of it is it's dead. No one there. Okay? Dig the ditch, put the heart in, you're done. Okay? From that. And then ultimately the problem is the cellular death. And we in the ED, this is where we diagnose you with that potentially from our high sensitivity troponins and all that stuff, EKGs. Think of it as a spectrum, okay? Some people have oligo or asymptomatic. Who would you potentially think of that's asymptomatic but they're having a heart attack? What? Women, yes. Okay. What?
I said us.
Uh-huh. What are the disease processes? I guess the sugars. Okay? Diabetes, because what does diabetes do to nerve cells? It kills nerve cells, so that they can't tell. Okay? Older patients is a factor. Okay? Because again, they don't have the nerves and all that stuff. So they may be completely asymptomatic. Okay? They may have some of the chest pain, persistent chest pain with, so either pain at rest versus with movement versus cardiogenic shock, and then ultimately, okay, the terminal of all ACS is flatline death. Okay? And we all will reach that at some point in time in our life. It's the most stable rhythm. Okay. So angina by the term, okay, is to squeeze. Right? That's all that angina means. Okay. So when we think about the chest pain or angina of the chest, it's squeezing. There's some other things that you can actually get infections that have the same type thing with the squeezing. Usually it's related to the narrow arteries from that standpoint. And the biggest piece or the biggest process is damaging to the heart from the lack of oxygen. Kind of sort of down in the pathway of how we assess it and treat it. Okay, what's the first thing, how do we assess it in the pre-hospital setting? What do you guys do when you roll up on scene? What do you ask? What's the problem? Getting your ample history. So the majority of the times we can do our amples and all that stuff. Okay? You get your blood pressure, you get your heart rate, you get your vital signs. Vital signs are vital. Okay? They're there for a reason. Okay? If you have someone that's a heart rate of 160, that's not normal. Okay? So you got to get the vitals and all that stuff. And then we'll get into the other things. Treatment-wise, okay, the life-saving aspirin, nitroglycerin is a factor that you can give based upon your local medical control guidelines, and then EKGs and transporting. So acute MI, okay, this is inadequate perfusion to the myocardium, okay, and the myocardium is the muscle around the heart, okay, and what's the purpose of the myocardium? To pump blood. Very good. So we don't get blood to the myocardium, or we can't perfuse. Okay? That means our blood pressure to that area is what? Not there. Okay? So it's potentially at that level, the mean arterial pressure for that is below 65, 50, and all that stuff. That's why we have to potentially adequate go from there. But it's all a perfusion problem. Okay? Damage to the myocardium. From there, you have an ischemic piece, or you can actually have the death of the myocardium, which is the infarction. Okay, kind of sort of how it looks. Okay, you can have different processes. If you have coronary artery disease, you get a plaque buildup. You can have a liquefied versus a fibrous. It can get bigger and erode in. The liquid can rupture and break off. Versus the other subclinical thrombosis, again, a ruptured either erodes through or ruptures off. Different processes from there. Hypoxia is the ischemia, and then ultimately, if you don't have enough oxygen, the cells die. It needs the ATP energy from oxygen. Other factors in play, okay, drugs can cause this. What's called coronary vasospasms can do that. From there, you get, of course, the plaque rupture, the thrombus breaks off. You can have too much oxygen. I'm running a race. I don't have enough oxygen. The mitochondria can't go through that. Cellular degradation, and it kills the mitochondria. I can't produce ATP. Yes, sir.
Explain. So when I came up with school, we gave 15 liters of oxygen to the chest.
Yep.
And I was always wondering why the nurse switched over to like 2 liters or 4 liters. So I know there's an oxygen issue.
Yep.
Affects the heart. What's going on there?
Yeah. So what let's talk about from the aspect of is oxygen-free radicals. And we'll actually talk about them in a second, a little bit, I believe. So when you get too much oxygen, oxygen will actually, in the form of too much of it, can bind across and form ozone. So you're actually making O3 versus O2, or you're making a single oxygen. So you actually, from there, you make radicals, oxygen radicals. When the oxygen radicals, what do? They go around and they destroy stuff. So they actually will destroy proteins and enzymes and all that stuff. So we were, in the past, we were always taught high flow oxygen at 15 liters. And for patients that's having an MI, that's actually the worst thing that you can do for them. Okay? Now, if they're satting 88%, yes. Okay? And our target goal is bring it to 94. Okay? That's your target. Okay? If they're already at 96, 97, you could potentially put them on 2 liters, just give them a little bit, but you don't want to put high flow oxygen, especially if they're having an MI. Because actually the literature out of Australia shows that it damages and worsens the problem. So, yeah, the whole notion of high flow O2 is dead. Don't do it. All right. Complaints, what do they feel? Okay, squeezing, aching, pain radiating to the jaws. Okay, fatigue that I talked about, nausea, vomiting, sweating. So diaphoresis, with the thing of, I feel like something is sitting on my chest, you're like an 85 to 90% potential having an MI. Okay? If someone says I'm being stabbed, okay, and it's fleeting in nature, it's like 15%. It's low. So what we're always taught, the stabbing chest pain is not a huge indication.
So it's not really painful, it's just really uncomfortable.
It's uncomfortable. Yeah, I got the elephant sitting on my chest, that bear, that gorilla, okay? My kids are sitting on my chest, okay? So chest tightness and they look diaphoretic, okay? They're having bad problems, okay? From there. The unfortunate nausea, vomiting, everybody gets nausea, vomiting. You stub your toe, you get nauseous and vomit, okay? So that's not a huge factor. In the aspect two, I don't have it up there, is the reproducible chest pain. Okay, you'll hear that sometimes. Oh, if you push on their chest, if they reproduces the pain, they can't be having an MI. Okay, unfortunately, that's a farce. That's a lie. Okay, 15% of patients that are having acute coronary STEMI or an OMI, okay, have reproducible chest pain. Okay, so don't let somebody that says, oh, they have reproducible chest pain, that they can't be having an MI, don't let them say that. Just say, screw you, have a good day. Okay, they need to be transported from that standpoint. 15% is what the literature kind of sort of shows. Assessments, okay? Of course, get your OPQRTST, get your vital signs, okay? And respiratory rate, do we make it up? No, we want to count because the number one abnormal vital sign is respiratory rate. Patients that are having a lot of problems, they start increasing the respiratory rate first. So that's the number one factor, especially with sepsis and MIs. They want to increase their respiratory rate because what do they want? What do they need? Oxygen, because their body is saying, because of the baroreceptors, remember the afferent side, on the baroreceptors, I'm getting too much CO2, I'm getting lactic acid around the heart, so I need to get rid of it, so it wants to breathe it off. So your first subtle sign that you'll get is an increased respiratory rate, okay? And we breathe 14 times a minute, okay? If I see you document 18 to 20, to me, you're lying, okay? We do not breathe 18 to 20 a minute. We breathe 14, 16, 12 a minute, okay? Once you get above 20, okay, that is abnormal. So if you documented 20, you already have the first factor of sepsis. Okay? So if you're going to lie, don't document 8 to 20. Don't lie. Phys exam. How do they look? Pale gray. Are they anxious, restless? Do they have swelling? Okay? Do they have fluid in their lungs? That's the pulmonary edema. This is why you need a stethoscope and listen to everybody. You got to see if you hear crackles or onchi and all that stuff. And are they wearing a medical alert bracelet? Levine sign, all right? Fred Sanford, you guys know who Sanford's son? Have you ever heard of Sanford's son? Okay. So this is 70s, 80s TV show from that standpoint. He's, Wilma! From there, he'd always grab his chest, clutch his chest, and scream out, I'm coming! Okay? But TV. It is, okay? But he did. Oh, sorry, Elizabeth. This is it, okay? Screams out and clutching his chest. That's the Levine sign when you have someone's clutching their chest. Okay? Just another indication for the angina and all that stuff. Feeling of doom. The other factor too, not Levine sign, is the poop sign. Okay? Someone says, hey, I got to poop. If they're having a heart attack and say, I got to poop, okay? We call that the death poop. Okay? And that means that they are on their last. Okay? If they look bad and they say that they've got to poop, it's just the body is trying to potentially expel everything, and that's not a good sign. Okay? Yes. So just things that many, many years of experience. So do we care? How do we take care of this? Okay? Position of comfort. Okay? Do they need oxygen? Meaning, okay, are they under 94 or over 94? Okay, if they're under 94, then yes, give them a little bit of oxygen. If they're over 94, maybe. Okay, they may or may not need from that standpoint. Okay, from there. Okay? Of course, if they're not breathing, what do you guys want to do for them? BVM, breathe for them, okay? All right? If they can tolerate an oropharyngeal versus nasopharyngeal, that's up to you guys, okay? You guys practice that and go from there, okay? Good EC seals and go from there. 12 leads, okay? Per National Registry, okay? National Registry allows you guys to obtain and transmit EKGs. State of South Carolina, you can obtain and transmit EKGs. Some states you can't, okay? Some agencies you can't, okay? So for you guys, okay, since this is a national registry process, you guys can obtain, I expect you obtain, okay? If you're on, when you do your testing and all that stuff and you get the EKG going, hey, okay, yes, I'm going to obtain the EKG and I'm going to transmit it. That is part of your purview as a national registry site. Okay? Yes? And if you work for, come to one of my agencies, yes, you will transmit. Okay? Expect you. Recognizing, we actually knew back in the 80s, if you actually go through the marching out how EKGs come about, 60s, that kind of saw the first one up in the northwest or northeast, and then it just progressed from that standpoint. Once we've been able to actually show and demonstrate the process of ECGs and then transmitting, you can actually cut down on the treatment, okay? So now the American Heart Association is door to balloon within 90 minutes. Okay, so some places you can't get that. So the faster that you can transmit or the faster you can go through, if they can see it, I can activate the cath team, I can get the doctor there because they're at home drinking margaritas, Mai Tais, whatever from that standpoint. Okay, they're not at the hospital all the time. Okay? So it takes time. So if you're out here in Pendleton, I'm 35 minutes, 40 minutes to GMH, St. Francis, you're 20 minutes, 30 minutes to Anderson. So you need time to get to the hospital, okay? If I can have the cath team waiting there for them, it's faster for them. Remember, it's all time saves or heart and all that stuff. How do we do? Console place electrodes, near the skin, remove any clothing. If they're sweaty, dead skin, remove that. And then, unfortunately, some people you do have to remove hair and all that stuff. This is why multiple electrodes are wonderful because you actually tear the hair off. Give them the Brazilian wax that they need. Placements, okay? From the aspect of how we do, okay? So the right arm, right leg, left leg. White on white, smoke over fire. Okay. White is your right arm. Left arm is smoke. It's black. Okay. This is standard. It doesn't matter if you're using a Zoll, if you're using a physical control, it does not matter. If you're in the ED, they all have the same. This is standard across the world. So the right lead goes to the right arm, the left lead goes to the left arm, and the left is the red, left leg. And this form was called Eisenhausen's triangle. That's the location, and actually it's a little bit higher up, if you're looking at the heart, of the process of how we get our lead 1, lead 2, lead 3s. It's from that triangle. And then the green is the ground is your right leg, okay? I put them shoulder, shoulder, belly, belly, okay? I don't put them on the ankles and all that stuff, okay? I do white, smoke, fire, ground, okay? So white on right, smoke over fire, and then the ground on the right abdomen. From there, you have your rainbow, okay? So the Christmas of the rainbow and all stuff, V1, V2, V3, V4, V5. So starting at the 4th intercostal, okay, V1, V2, and then it drops down V3, the nipple line, okay, V4, V6 is all the way to under the axillary, and V5 is in between. Okay. If they have pendulous breasts, what do you need to do? Lift them up. Okay. Don't put it on top of the breast. Lift the breast up, get it underneath of the breast. Okay. This is where the ideal location of that is. Okay. So fourth intercostal is V1. Fourth intercostal on the left sternal, V2. I do the V4, so right under the nipple at V5. I do V6 under the axilla, and then I'll go back and I'll put V3 and V5 in between.
I'll teach y'all how to do that.
Yeah, and we'll practice all this stuff. Okay, it's very important on location because if you move these up, actually changes the electricity because it's all based upon electricity and impedance. So if you change the location of it, you can actually change what I'm seeing on the EKG, or in the future, when you as paramedics, what you're seeing on the ECG. It does have a very important factors. Posterior wise, if you're thinking that they may be having a posterior, okay, or the left anterior, the left circumflex that goes down, that I told you about that one, the left posterior, maybe not, okay. What we do is we take V4, V5, 6, and we wrap it around the other side. Don't worry about that, it's a play for later. But it is there, we do that at times. Yeah, life-saving aspirin. There are only two things that have been documented, proven benefit for patients having MIs. Aspirin and?
Nitroglycerin.
Nope.
Oxygen.
Nope.
Oh,
Heart catheter.
okay.
The only two things that have been proven beneficial is aspirin and getting them to the heart cath, okay? Which means getting them to a PCI center. Yes, everything else is helpful, okay? We want to give them a little bit of oxygen, it makes them comfortable. We want to give them a little bit of nitro because it may make them comfortable. Okay? Giving them heparin, it may help out a little bit. Okay? Give them morphine, that's the old Mona from that standpoint. Morphine has. I actually give midazolam, I have my crews give a Versed, which is a anxiolytic. Because when I increase heart rate, what also increases? How much oxygen you need. If I can decrease your heart rate, I can decrease the amount of oxygen you need. Thereby, I can actually de-evolve STEMIs because of oxygen, because heart rate goes back to heart rate times stroke volume is
Cardiac output.
good job, cardiac output. Okay, so heart rate is independent, is an independent marker of how much oxygen we need. We increase our heart rate, we need more oxygen. Because the heart is working faster. I need more oxygen for the heart to work. All right. So, indications for not. Risk of aspiration, okay? If they're comatose, don't give it. Okay? I'll squirt it up, I'll put it up the butt later. Okay? I have suppositories. Okay? If they've already taken a full dose is 325 milligrams. Okay? Or 324 if they've taken 4 baby aspirins. Okay? If they have a true aspirin allergy, if they say, hey, it upsets my stomach and you're having a heart attack, oh boo-hoo, give them the aspirin. Okay? If they say, hey, I go into anaphylaxis if I take aspirin, guess what? Don't give it. Okay? That's the only true allergy. If I go into anaphylaxis. Okay? If I have a recent GI bleed, this is a plus or minus one, okay? They say it in the textbooks and they might say it on the test, a GI bleed. Would I give it? Yes, I would. Because again, what's the only two things that have been proven benefit? Aspirin and PCI, okay? And most of the time this is taken care of. If they're on a blood thinner, again, blood thinners work in a different pathway. This is usually in consultation with my cardiologist. I may or may not give it. So how does aspirin work?
I teach them at that point, if they take a blood thinner, call ER, ask the doctor to order.
And that would be the consultation, med control, and all that stuff. And I would probably just tell you, give it to them. If they're having a true STEMI, just give them the aspirin. It's not a huge factor. All right. So how does aspirin work? Okay, aspirin is an anti-inflammatory. Okay? It's one of the NSAIDs. It's a non-steroidal anti-inflammatory. Okay? Meaning, what it does from there is it blocks this process. Okay? Thromboxane is one of the products in the pathway that causes platelets to stick together or to activate. Right? Remember, what do platelets do for us? What do platelets form? Clots by forming that mesh network. Okay, what? It's our spider web. Okay, the platelets are the spider webs. Okay, the megakaryocytes and all that stuff, where it's made from. So that forms that clot, fibrin clot, and all that stuff. So from there, if I stop the fibrin clot, or if I stop the meshwork from being made, okay, it can then be broken down, excuse me, which in turn stops the clot, or I can dissolve the clot. The other thing is it makes the platelets sticky, so the platelets can't stick to each other and they slide off and they keep going on. Okay. And then again, they stop the blood clot formation. Okay. Nitro. Okay. Nitroglycerin is not, okay, proven benefit for reducing MIs. Okay. Okay. But we give it because we're nice. Okay. We want to alleviate pain. Okay. And why do patients call 911? They're having pain. Get rid of my pain. Okay, that's all that they want. You guys, you can administer nitroglycerin if it's on hand, and depending on the state, okay, for stock and all that stuff. Okay, so from the aspect of national registry, that's kind of sort of the factor. Each state, wherever, depending on where you go to as an EMT, the state may or may not allow you. Okay, but your skill set and all that stuff is, if it's the patient's medication, you can administer it. Yes? Anything else? Okay. So, how does nitro work? Okay. Nitroglycerin is actually converted to something called nitrous oxide. Okay. Nitrous oxide. Okay. What does dentists use? Laughing yes. Okay. That's basically what nitrous oxide is. Okay. As EMTs, you guys can actually use nitrous oxide in the state of South Carolina too. Okay, as an adjunct pain medication. Okay, so we give nitro. Nitro was converted through this whole process into nitrous oxide, which then goes over into the smooth muscles, the coronary vessels, the lungs, and all that stuff, and it stops calcium from binding. Okay? When I stop calcium from binding, what does that do? Going back to the physiology, the actin, the myosin filaments, okay, you have the troponin, the tropomyosin, the contraction for the ability for the myosin head to bind to the actin, which allows for the contraction. So if I stop that, if I get rid of calcium, I stop the contraction process. When I stop the contraction, what happens to the blood vessels? They dilate. They open up. And when I open up blood vessels, it's to the radius to the fourth power. Okay? So every millimeter potential increase is actually as a diameter distance to the fourth, to the radius and all that stuff. So I have potential profound effects of allowing blood to flow through something that was originally constricted down. And when I open it up, what do I allow through? Blood, which also has oxygen and nutrients in the form of glucose, okay? Because that's what it needs, okay? It needs glucose, it needs oxygen. If I have those things, I can go through Krebs cycle, electron transport chain, and produce ATP. I can get rid of lactic acid because I'm no longer going through the pyruvic acid cascade. Ooh, another day. Anaerobic respiration. That's what you're getting rid of. You're getting rid of anaerobic for aerobic. So again, just the treatments, a little bit of oxygen if they need it, 12 lead from there, ST changes, okay? And you guys should, when you get out, you should be able to look at an EKG and say, that is wrong, okay? When you see tombstones on the ST sides, I'll teach you later, okay? From that standpoint. All right. Ask about, again, for nitroglycerin, most guidelines, protocols, if you have to have a MAP over 65, Most individuals, most agencies, systolic blood pressure greater than 120. I'm scared, okay, as a medical director, with nitroglycerin in the hands of an EMT, okay? And it's purely for the aspect of if you give it and the blood pressure drops, what can you do? Nothing, okay? So if their blood pressure is normally 120, you give them the nitroglycerin, now their blood pressure is 60, what are you gonna do? Exactly, except change your underwear and all that stuff, okay? Code brown, go from there, okay? So this is why as a medical director, I get scared with nitroglycerin in the hands of an EMT, okay? So I don't really allow it for my agencies. The other question you had to ask, make sure, is any of the sildenafils or the erectile dysfunction medications, Viagra, Cialis, and all that stuff, or they're what's called phosphodiesterase inhibitors. Right? If they had any of that within 72 hours, 48 to 72, it can actually increase the effects, and the blood pressure can really drop down. Okay, so make sure you ask them that, older patients, before you give the nitro. Supplemental 12-lead aspirin, life-saving aspirin, I don't care, give that nitroglycerin, and they need to go where? To a hospital that has
You just said it.
PCI capabilities, okay? Percutaneous intervention, a PCI center, okay? This is not the time that you take the patient to a Coney, okay, if they're having a STEMI. This is not the time that you go to Cannon, okay, from that. Baptist Easley, no, okay? This GMH, St. Francis, Anderson, Self, you need a PCI center. Right? How you give it? 1 dose, 5 minutes. Okay. If they're still having pain, give them some more. Make sure you're looking at blood pressure. Maximum for you guys is 3 doses. If they're still having pain, but it's better and you give them 3, call med control. Hey, can I give some more? Okay. Along with the blood pressures and all that stuff. I've actually given to the point that every 5 minutes, just if their blood pressure is good, technically you can give it to them. Okay, from that. Until you get them to the cath lab. So complications, okay? So what are some of the complications from MIs and all that stuff? Think of Darth Vader, okay? Death, it's a very bad complication, okay? We don't like that complication. Arrhythmias, they can go into VFib, VTAC, okay? They can go into heart blocks, okay? First degree, second degree, third degree heart blocks and all that stuff, different place. They can actually develop AFib, aflutter, different pieces. Rupture, okay? The papillary muscles that I talked about inside, okay, they actually rupture off. No, I have a valve that doesn't work properly, okay? Or the ventricle itself ruptures, okay? The ventricle ruptures, what happens? Where does blood go? Not in the heart. It goes out into the chest and all that stuff. And they go back to number 1 is they die, okay? Tamponades we'll talk about in a bit. Heart failure we'll talk about. Valvular dysfunctions, again, the aspect of it does. Aneurysms we'll talk. Dressler syndrome is a post-myocardial infarctions. They actually develop some irritation of the heart that they'll have 2 to 3 weeks later after the fact. They get some fluid around the heart. It irritates the heart. They get this bad chest pain and all that stuff.
How common is that?
Not 10, 15%. Not a huge. Okay. Of course, always the risk for embolisms, because if they get AFib, they get clots made into the atriums that gets then into the left ventricle, which then breaks off and goes to the brain, and they get strokes. Or they can have ischemic guts and all that stuff. So all bad stuff. And then the unfortunate is the fuse, they may have a reinfarction, which is never good. Okay. The concerning, the most problematic complications of cardiac disease is they die. Okay? Cardiac arrest management. Okay? Whose wheelhouse is cardiac arrest management in? Is this a paramedic thing? Is this an advanced EMT thing? Is this an EMT thing? Is this a firefighter thing? Is this a layperson? Who owns cardiac arrest?
Whoever knows CPR.
Whoever knows CPR. Okay? That is how beneficial, because the only thing that has been proven benefit of out of the hospital cardiac arrest. ROSC is how fast and how quickly someone starts doing CPR. That's it. This is why dispatch, we actually teach TCPR, so telephone CPR, or the telecommunicator CPR. Teach people how to do CPR. Right? You don't need to do breaths, you just need to do hands-on. Okay? That's it. Chest compressions. Okay? After that, okay, EMTs, firefighters. Okay? You guys own this. Okay? I don't care about the best paramedic in the world that can intubate 1 million patients and has all the wonderful gadgets, okay? If you're not doing high quality CPR at a rate of 100 to 104 beats per minute at a rate of depth of 2, okay, you're not gonna get the patient back. So the paramedics suck at this. Okay? That's why you actually, if you look at the triangle, okay, or pit crew CPR, which I'm not going to talk about today, but when you go, okay, inside pit crew CPR, inside the triangle, paramedics are not inside the triangle. They are outside the triangle. They have the monitors outside, they can drill the patients outside, and they push medications outside the triangle. Who's inside the triangle? CPR, that's it. Which is who? EMTs and firefighters, okay? The hands in the hands of the best high quality CPR is going to be your firefighters. Let them do CPR. All right. CAB, okay? Coronary airway breathing, okay? Medical devices, they actually, if you look at the AHA guidelines that just came out last week or a couple days ago, they actually had a lot of different changes from that standpoint. All right? Mechanical CPR devices are not there. Still, test-wise, this might be a test question, all that stuff, okay? For now, until it goes away. I'm a good fan for mechanical CPR. If you're by yourself, you don't have a lot of hands, they work wonderful. Or if you're going to transport a patient, they keep going and you don't get in car accidents and people get injured. That's where mechanical goes from there. AEDs, we'll talk about more. Take home. Okay. Airway. Okay. If you have an airway obstruction, you got to get the airway open. Because if you don't get the airway open, guess what? They're going to die. Okay, you got to get the airway. Okay, shows from that standpoint. Okay, chest compressions or compression fractions. This is a new term that you'll see. You guys don't always see it live there. This is what we see on the backside when we start doing CQI processes. Okay, we actually see how well you're doing with hands-on the chest, compression. Okay, and it's a magical little number that we go through, and this is kind of sort of what it looks like. Okay, so they breathe, and nothing. They do a little bit of CPR, nothing. Breathe, nothing. Oh, then we do some CPR. Then we, nothing. Okay. What's the outcome for this patient? Yeah, exactly. So then, okay, this is what we want to see the whole time. Is this at the 17-minute mark? If you have that the whole time, and this is a little fast even, okay? But you want to see all the red lines the whole time, and then you get a breath, and you may have a slight less than 10-second pause in between, okay? So, first key point, compression fractions matters. When we look at the numbers, the totality and all that stuff, again, you won't see it while you're doing it. You need to ask your CQI people, how did I do? Okay, and if your CQI people are not giving you that information, they're doing you a disservice. Okay, you need to know how you're doing. So ask the questions. Get on the chest, stay on the chest. Okay, keep thumping until the code stops. If you have a paramedic that says, hey, stop CPR so I can intubate, what do you tell them? F off, okay? Straight up, okay? If they say, stop, I need to intubate, Dr. Shireen said, no, okay? You get on the chest and you stay on the chest at a rate of 100, 104 beats per minute, and you do not stop until they're dead or you get them back. You don't stop, because that's the only thing that has been proven benefit. Minimally interrupted, so MICR, okay, minimally interrupted cardiac resuscitation. You can read through this whole thing. Again, it's the same thing that I talked about. Don't stop CPR. Don't interrupt, Okay? Because once you start interrupting CPR, our perfusion pressure drops down, and we have to take time to get the perfusion pressure back up again. Okay? So don't stop. Survival shows implementation of MICRs as an alternate EMS. We do this. Most high-quality CPR systems, most agencies that have high-quality CPR does this. Okay? If you want to learn it, come to Pickens County, we'll let you play. Okay? Don't care. Don't stop CPR. Okay? From there. All right. Public service. All right? As you can tell, I love Star Wars. Okay? Darth Vader. Okay? From that standpoint, if you put it on, so Stay Alive, Another One Bites the Dust, the Imperial Death March, all of them, they're about 100 to 104. The Imperial Death March is at a rate of 104 beats per minute. Dun, 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 dun. Okay? And that's the rate that you want it at. You don't want it too fast. You don't want it too slow. Because we show, okay, the ideal compression rate between 100 and 120 beats per minute. Again, 100 to 105 is the kind of sort of the target, but we've all the literature, if you're between 100 to 120, we have better outcomes. If you're less than 120 or less than 100 or over 120, if you get that zealous firefighter, okay, you get the 18-year-old just got his fire one card and he's standing there and he's doing CPR, you have to slow them down. Slow down. Turn on the metronome. This is why I carry a metronome on my phone. Because if I see that, what I do is I put the metronome on, it's already at 104, and I turn it on and I put it on the patient's chest. Okay? And it goes tick, 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 and they go to that rate. Okay? That's the whole process. So, compression rate matters. Defibrillate. Okay? Yes, I said earlier from the aspect of for STEMIs, what are the two things for life-saving for STEMIs? Okay? Aspirin and PCI. Okay? For cardiac arrest, the only two things that have been proven beneficial is high-quality CPR and early defibrillation. Okay? The only two things. I don't care about all the drugs, amnios, epis, all that stuff. None of it has been proven benefit. The only thing that makes outcomes is high-quality CPR, who's done by firefighters and EMTs, okay, in early defibrillation, who I can get my blue canaries to do, my law enforcement officers, okay, because they're the first ones on scene. Yes? Law enforcement, I love my brother in blue, okay? Love them to death, but they're my blue canaries. I teach them AEDs and CPR. They carry AEDs and they do CPR for me, okay? Because they're on usually first, right? Depolarize from the aspect of 75%. The longer you delay defibrillation, the longer or the potential you can't get them back. So early. All right. For you guys, automated CPRs, follow them on, all that stuff, different factors, different plays, different companies and all that stuff. Okay. Again, the whole purpose of it is to use for individuals minimal training. Frequency, VF, okay. Initial rhythm, get them out, diminishes rapidly over time. If you delay, it's like by every minute you lose 10% ability for them to actually, or 10% of the ability to convert them out. So if you get to 10 minutes, if they're in a VFib, you almost have a 0% likelihood of getting them out of cardiac arrest. That's why it's so important to start CPR and early defibrillate. AP versus lateral, okay, the locations, okay, and they did talk about this on the 2025 AHA. So AP, of course, is anterior, posterior, okay, so anterior, left side of the chest, posterior, behind, Sando Sheen, okay. That is the ideal kind of sort of process or where it should go. So my crews and all that stuff, I try to get them to do the AP first. If you can't, you're by yourself or whatever, and you can only get to the anterior lateral. So the anterior vector changes. You put it on the right chest and the left, okay, left lower. Because what are you trying to sandwich in between the electricity? The heart, okay? Trying to sandwich the heart in between. So you're trying to defibrillate through that stuff, okay? Of course, things to take into consideration, patches, okay? If they have piercings, they should be within outside of an inch. Any other patches, if they have a port or a pacemaker, you should try not to be on the within an outside of an inch of that, because there's a theoretical that could actually, electricity can go through that, okay, from there. Don't make contact during the defibrillations, okay? I'm clear, you're clear, everyone clear. Shock, go from there. Okay, weather, rain conditions, okay, snowy weather, okay. I've actually had discussions with Zoll, physio, and all that stuff. Is yes, it can be used, okay. You can be on a wet patch, you can be almost, the patient could be there and you're not gonna get shocked and all that stuff, okay. Now, if it's a rainstorm, there's a lot of lightning, do you want to be doing CPR in the rain in the first place? Yeah, that's for you to decide. Okay? I personally take the patient in the back of the ambulance and go from there. Okay? I wouldn't definitely not be on top of a roof doing CPR in the middle of a rainstorm. But it is what it is. Okay. Perishock pause. Okay. Independent predictor of survival, okay, cardiac arrest. Meaning the less perishock pause that you have, the better chance that you have. Okay. Remember going back to that compression fraction that I showed? All that dead space, all that time that there's nothing was going on, that's the perishock pause going on, okay, from there. Also means that when we go, okay, I'm getting down to the 2-minute mark, I'm gonna do my defibrillation, I charge the monitor, and so I can automatically defibrillate. That's the other process of the perishock pause. So, pause length matters, meaning what I'm doing, I don't want to stop CPR for more than 10 seconds, okay? So if I initiate the system, we're doing CPR, someone starts counting down at 1:45 to 2 minutes, 1:45, someone goes to the monitor, they charge the monitor, okay? They dial up the joules, and then from there they get the monitor, it starts beep, 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 it's ready to defibrillate. You get the 2 minutes, check for pulse, look at the monitor, rhythms if they're in VFib, VTAC, you defibrillate, immediately go back on the chest, okay? Crews, they can get this done within 5 seconds, okay? Really, again, because what's the number one thing that's been beneficial for cardiac arrest and VFib, VTAC? CPR, chest compressions, and defibrillations.
And that's why when if you're doing an AD, when it charges, you on the chest. When it says shock at 5, hit the chest, do compressions until you're ready to shock.
That is correct. Unfortunately, it does take a little time to analyze, which I don't like. But that is what it is. All right. All right. Limit your perishock pause. Control the rate. De-emphasize ventilations. Okay. We don't really do breaths at Pickens County for the first 5 minutes. So I'm a non-rebreather from that standpoint. I don't care about ventilations. You have 16 to 18% oxygen in your bloodstream. I don't care. Get on. This is why the whole notion of hands-only CPR works. Okay. Circulate the blood, circulate the blood, circulate the blood. Okay. Don't worry about BVMs and all that stuff. Chest compressions, depth. Okay? We know that depth really does matter. Versus, driving through the back. Okay? They actually now, even the AHA, the notion of the cardiac for the pediatrics has changed. They're no longer doing the 2-finger method, either the hand encircling or the palm only. Okay, from those, the 2-finger method is dead. Okay, so yes, chest depth matters. Okay, you have a witness. Okay, begin. VFib, chest compressions. We defibrillate. We compress. We look. We compress. We shock. We compress. We rhythm. We compress. We shock. What's the theme? Compress. Okay, that is the theme. Okay, I don't care what you think, how you think. Okay, The core management is one thing. I don't care if you're in a PEA arrest, asystole, VFib, VTAC. I don't care. The core is simple. Chest compressions. That's all that matters. Kids, okay? Kids we don't have problems with them having cardiovascular problems. They usually die from some other processes, okay? So their number one issue is usually airway compromise, okay? Yes, you can get some of the congenital kids and all that stuff. Rarely do they actually die from a heart attack where they have an occlusion of the heart and all that stuff. Sepsis, airway, all that stuff. The only consideration, okay, is the kids playing ball, okay? Your basketball players, the sudden death, football players, basketball players, it's called HOCM, so hypertrophic obstructive cardiomyopathy. These are the kids that run into, actually had a school bus kid. He's run to the school bus, went down, okay, from that standpoint. CPR, they got him back and all that stuff. But those are the ones where they need AEDs. That's why a lot of schools carry that.
I can't think of the term. What's the NFL football player?
Oh, the cordial-commotio. Okay. So the other one is the cordial-commotio. That's where they get a direct impact to the chest. The unfortunate, I had one of my pulmonologists back in 2001. His son was hitting a tennis ball up against the backstop. Tennis ball hit, struck him, went down. He went straight down. And they didn't get him back. And he's only like 10 or 11. So that's the cordial-commotio. That's the one football player that got struck and then went down. Okay. So when do we stop? Okay. So inclusion criteria, exclusion criteria, and then based upon different procedures and all that stuff. I use OPALS, which is the anterior pre-hospital life support. So BLS is you look at your timing, 25 to 30 minutes. Was it witnessed, not witnessed? End titles have a little bit of factor playing in all that stuff. So your guidelines will kind of sort of put in that. All right. Guys want another break? Keep going. It's a lot of information. Okay. All right then. All right. So moving away from ACS. So again, ACS is a spectrum: coronary artery disease, angina, STEMI, OMI, depending on terminology, and then cardiac arrest, okay? This is the unfortunate, the complications of usually from an OMI from that standpoint, okay? So when we start looking at heart failure, love it, okay? Heart failure treatments have changed over the past 15 years for a number of different factors, okay? In the hands of an EMT, you guys can directly impact on how the outcome for patients, okay? As an EMT, you guys have direct impact just because of using of CPAP, okay? From that standpoint. So, and in the future, I'm actually gonna do some research where nitroglycerin with EMTs and all that stuff, where you guys give sublingual nitro for CHF, because that's what really helps them. So how it works, okay? Remember, all right, from the aspect of kind of sort of what we're looking at with heart failure is the considerations for the acute pulmonary, okay? The lungs fill up with fluid, okay? If the lungs fills up with fluid, what side of the heart is not working properly? The left, okay? So if the left side of the heart's not working properly, where does the blood go? Into the lungs, okay? If I get more blood into the lungs, where does it want to go? It wants to leak out. Remember all the seawater, okay? The plasma and all that stuff, it will diffuse outside. Osmotic diuresis, osmotic gradients and all that stuff. Pressures, okay? A whole different topics, okay? So that's the whole aspect of with left-sided heart failure. Left side, blood backs up to the lungs, okay? If I get water in the lungs, what am I gonna hear? What should I hear? Gurgling, okay? Will they have peripheral edema? Why? Good. It's the right side, okay? So when you have right side, if you have peripheral edema or the liver is engorged, Kids can get CHF too. Okay. So I had a 5-year-old that had a cardiac arrest and CHF from a viral infection, and his liver was engorged. Babies, liver engorged with when we talk about some of the cyanotic diseases and all that stuff. Okay, so push on, look at the liver as a indication. Okay, do they feel a little bit more short of breath? Do they have the aspect of the pitting edema in their legs over time and all that stuff? So different factors. Okay, and then compensate. So how does it work? Okay, we talked about this. Okay, we talked about the heart. There's a mechanical side and an electrical side. Yes. Okay. So in heart failure, is there a problem with electrical components? No, there's not a problem with the electrical side. Usually. Okay. Yes, you may have AFib or something like that you throw some electrical off. But traditionally, it's not a electrical side. So that means it's a mechanical. Okay. So how the dysfunctions, okay? You have a systolic and a diastolic dysfunction, meaning is how does it, and I should have thrown in the POTS. I forgot the bucket methods. I'll have to do that later. So the dysfunction, again, the heart, the blood comes from the atriums through the valves into the ventricles and then pushed back out and squeezes out. Okay. When in a systolic dysfunction, okay, remember what I talked about with the stroke volume? Okay, what's the normal stroke volume? 70. Okay, so when the heart, if you look at this top one, okay, is that heart bigger or smaller? Bigger. So the one on the right-hand side, it's a bigger heart. So it's a floppy heart. So we've taken the rubber band and we stretch that rubber band out. Okay, if I stretch the rubber band really well, can it squeeze well? No. I want, if it's too stretched, okay, because that goes back to my actin and myosin filament. If I stretch them apart too far, can they connect together and make a contraction? No. So I want that right distance. Again, too close, they don't get a good squeeze. Too far, they don't get a good squeeze. So when I get a big floppy heart, okay, from that aspect, I don't get a lot of squeeze out. This is where we go back to that EF of 20, 25, 30%. I don't get a lot of the stroke volume out. Okay, I go from a stroke volume of 70 to a stroke volume of 35. Okay, so if I have a heart rate of 70 and my stroke volume's 30, my cardiac output is now 7 times 3 is 2100. Okay, that's now my cardiac output. Okay, is that good or bad? Bad. Okay, so we reduce the ejection fraction by 50%. So they now have an EF of 25%. So their cardiac output is only 2100, so they don't have enough. So what does the body have to do to compensate? It has to speed up the heart rate. Okay, when I speed up the heart rate, what do I need to do with my oxygen? I need to breathe faster. I need more oxygen. I have a higher oxygen demand. See how all that comes together? Yes? Pathophysiology, gotta love it, gotta understand it. All right. Versus the other one, okay, on the diastolic dysfunction, okay, so a normal heart, the ventricles, you get a big ventricle, okay? The left ventricle is just big, okay? It's just a gorilla standing in the door, okay? And if the blood is trying to get in there, can it get into the ventricle? You got this huge bully standing at the door, okay? It can't get in. So I don't get enough blood into the ventricle for it to be able to push it back out, okay? That's the diastolic dysfunction, okay? Big ventricle, it's thickened. I just don't get enough blood in there to be able to squeeze back out. The squeeze is still good, but I don't have enough to push through. So again, systolic, okay, pumps less, okay, diastolic, fills less. Big and all that stuff. Okay. So heart failure, pathophysiology. Oh, okay. So again, going back to our afferents and our efferents. All right. So on this, what we look at, our chemoreceptors, we have problems. Our baroreceptors, we have problems. We don't get enough blood pressure going through. Okay. The chemoreceptors, we're seeing more CO2. Okay. We see more acid going on. Our muscles, we might have some lactic. All that sends a signal back to the heart or to the brain saying, hey, things are screwing up. So I don't get the blood pressure that I need. So what the system does, okay, is it tells the kidneys and the heart to do a couple things. It tells the kidneys to release the renin, okay, angiotensin, aldosterone. Okay, vaguely, I know you guys, okay. So renin and angiotensin does what? It increases the blood pressure up, okay, because that's the ACE inhibitor, okay. So angiotensin increases the blood pressure. Aldosterone, okay, increases the water intake. Okay, so I actually pull water back into the system, okay, because I need more blood pressure. That's what it's thinking. When I increase more water into the system, what does that do to a heart that's already stretched? Makes stretch harder, which does what? It does it's even worse. Okay, so now I also, with the angiotensin, I take the blood vessels and I squeeze down on the blood vessels. Okay, what does that do to my blood pressure? Actually, it increases the resistance. It actually increases the blood.
The bigger it is, the lower the blood.
Yeah, because it's the diameter. So it squeezes down on the blood pressure, or squeezes down on the blood vessels, which will increase the blood pressure. Okay, so the heart is having to now, instead of my little 7-year-old at the door holding the door open, okay, I'm standing there holding the door open. Are you going to move me from the door? It's going to take a lot to move me away from the door. So that resistance, that afterload, remember that? So my afterload increases significantly. So now the heart has to even work harder. So it's being stretched, and at the same time it has to really work hard to push through. And it says, screw it, I'm done. Okay? And that's the problem that we have. That's heart failure 101, in essence. We get too much fluid, and the heart has to push against a constricted down system. Then from there, it'll start increasing because, again, heart will increase because it's trying to preserve cardiac output. It can't do that. It needs more oxygen. It can't do that. And it goes into problems. So, assessment, okay? Medications. What do we want when you're looking at medications? What they may be on? Okay. What medication may they be on to help them with fluid? A diuretic. Okay. Do you know a common diuretic that they're on?
It starts with an F.
Okay. Yep. Furosemide. Okay. Do you know the trade name for furosemide? Lasix. Okay. Lasix. Okay. Do you know how it got its name? Lasix lasts 6 hours. Okay. That's how Lasix got its name. Okay. The other aspect of it is, the term peeing like a racehorse. Okay. How did they get that term? They would actually give furosemide back in the 70s, 60s, and 70s to the racehorses to diurese them off. They gave them shots of Lasix, and then they peed out. That's how they got that term. Okay. That's extra free for you guys. All right. So looking at pedal edema, of course, that JVD, venous vagal distension, okay, when you're laying flat versus sitting up, do you actually have is your jugular vein distended, okay, which is a marker for right heart failure because the fluid is backing up and going from there. And of course, your heart, lung sounds and all that stuff, okay. Normal heart, enlarged heart, swollen edema, bloated stomach, they get lung fluid and all that stuff, okay. Their level of consciousness may be altered. Why? Why is their level of consciousness altered? What? They don't have enough oxygen, but more importantly, they have too much CO2. Okay? It's the kind of, they may have enough, just the right amount of oxygen, but they have actually too much CO2. They can't blow it off because the heart's not working to get the CO2 out. And they got fluid in the lungs, so they can't diffuse the CO2 across. So they get CO2 retention, all that stuff. Right versus left, okay? Different valves. Again, you guys are doing a wonderful job with that. Keep studying, keep practicing, okay? Left heart failure, pressure buildup, leaks into alveoli, impaired, pulmonary edema, okay? Life-threatening. Again, not pitting edema, not liver engorgements, nothing on the right side that we see. It's all inside the lungs, okay? So they can look normal elsewhere. Noisy, cough, rails, wheezing, okay? They get this strawberry margarita, or your daiquiris, okay? The strawberry daiquiris, how that's kind of sort of what pink throcky sputum looks like, okay? It's blood tinged and there's this white, it just comes up and all that stuff, okay? And remember, okay, they can actually be wheezing. I have patients in heart failure that are wheezing because it's all wheezing is just air turbulence. Okay? So don't think, okay, the aspect of not all things that wheezes is asthma. We're taught that over and over again. Okay? Heart failure, or they call the cardiogenic wheeze, is your CHF. Right-sided, most common, is usually because of left-sided. Okay, the right side is a low pressure versus the left. The right side is trying to push against to get blood into the lungs. It can't get into the lungs because there's all this fluid in there. So the right side says, screw it, I'm done. Okay, taps out, goes home. All right? So when the right side fails, what do we see? What else? JVD, what else? Swelling, okay. Go back to the liver. Look at the liver. Liver engorgement, all that stuff. Okay. Pressure builds up, JVD, swelling, abdomen, pit edema. Okay. Usually, okay, COPD has a factor. Left heart failure is the most common. COPD or cor pulmonale, so I increase pulmonary hypertension in the lungs. I get too much pressure in the lung. I can't get it out. I just can't get the pressure inside of that. Heart disease problems, embolies, PEs, pulmonary embolies, and RV infarctions. Okay. Head is kind of sort of your mnemonic: edema, hepatomegaly, ascites, and the distended neck veins. That's the kind of sort of the factors that you'll get from all that factors it plays. Some people that are wheezing, if they have edema in their legs, okay, if they have a little bit of wheeze, okay, they may have a little JVD, okay, they do not need this, okay. Nothing really irritates me more than to see my EMTs and paramedics that yes, I see it all the time, okay. I've pushed and hard, okay. They don't need albuterol. Albuterol is not going to need or do anything for them, okay. So what do? We treat, okay. Sitting them up, dangling, okay? Sitting someone up, what does that do to the fluid in the lungs? Makes it goes down. Let gravity be your friend. Have them lay flat, it's a no-no, okay? Putting their feet down. Let gravity pull down, okay? Engage the capacitance vessels from that standpoint, okay? Assisted ventilation, CPAP, monitor vital signs, and if they're really, really bad, there's something called SCAPE. So sympathetic crash and acute pulmonary edema, they need ALS and all that stuff. You guys, this is you, okay? CPAP is you. Okay, so continuous positive airway pressure. Have you guys done that yet? Played with it yet? Okay, yes? It's one of your skills that you did checking off last week? Okay, yeah? Okay. So this is you guys. It depends on you use the FlowSafe 2 versus the Pulmonine versus a mechanical CPAP. There's a whole bunch of different ones out there, okay? And it's all based upon PEEP, okay? So CPAP is non-invasive. What it does is it increases intrathoracic pressure. When I increase intrathoracic pressure, the blood, okay, it's trying to get back, but it can't. So when I increase intrathoracic pressure, what does that do to my preload? If I can't get blood back, what happens to my preload? It does. So my preload drops down. Okay. So what does that do to my heart? If my heart is this, what does it do to my heart that's already stretched? It shrinks it back down again. It allows the heart to get back down to its ideal location. So now, okay, allows for my actinomycin to bind, which in turn allows for my stroke volume to increase, which increases my cardiac output. Okay? Yes. Okay. And it all does this because of the capacitance vessels. The capacitance vessels can take the pressure. You pushing it down into the legs, into the veins and all that stuff. You keep it out of the chest.
I got a question. I want to see what your thoughts are. So I wear a CPAP. When I put it on, the machine will cut on automatically at my breath. If I pull that mask away, it's like a tornado comes at me. So I don't feel the air if it's already made the seal. With the CPAP, if they're applying CPAP, would it hurt to disconnect the hose, put the mask on, instead of having that air coming at them and they psychologically feel like they're going to get smothered?
Yeah, so the aspect of the question is putting the mask on before attaching the hose. And I've seen a lot of people that they don't tolerate it from that standpoint. Yes, so I've actually seen sometimes that they'll just put the mask on, not put the headband on, put the mask on and then turn it on. And then that allows them. Put the mask on, then attach to the hose. Sometimes it does take them a little bit to synchronize with the CPAP because it is the potential that they feel too much and they feel like they're getting smothered. And everyone's always a little play. And then unfortunately, sometimes some people, they just need a little bit of midazolam just to calm them down, to drop the edge. They get too much from that standpoint. Usually once they get the feel of it, and everything starts expanding open, they feel so much better. But yeah, different tricks, different plays, and you can try. I mean, you can put it on, see if they fit it. Usually what I do is, if they've never had it before, I'll put the mask on first, and then turn it on, just let them have the mask before I attach their head and all that stuff to it. Yeah. So what the whole purpose, CPAP, so continuous positive airway pressure, is PEEP. So positive end expiratory pressure. How much pressure is at the end of breath? Okay, that's the positive end expiratory. So when you try to blow up a balloon, what's the hardest part of blowing up a balloon? Starting it. Okay, so starting the balloon, that's the hardest. So what PEEP does is it stents everything open. It keeps the balloon open just a little bit, okay? Usually 5 millimeters of mercury, maybe 10, depending, okay? So just a little bit that keeps it open, so the next time it gets a breath, it's easier for that to breathe. So it reduces their work of breathing. When I reduce my work of breathing, how much oxygen do I need? I need less oxygen because I'm not needing as much ATP because I'm not having the muscles work as hard. From there, redistributes the fluid, and then kind of sort of recruits some of the bottom lungs and all that stuff. So last week I talked about the aspect of with the inside the lungs with asthma patients, how you might have your oxygen level will dip. Okay, so it's kind of sort of the same thing here, that you have some areas of the lung that are not getting aerated or oxygenated as well. So once you put them on, your CPAP, or so your pulse ox might dip a little bit at first because you're getting areas that are not oxygenating well, and you have blood that starts circulating back to that area, and they're not grabbing oxygen, so it comes back out into the bloodstream, deoxygenated blood, so their SpO2 might dip, but they look better. What do? Nothing. Stay the course, okay? Same thing like with your asthma patients. If you give them a breathing treatment, their SpO2 dips, do nothing. If they look better, stay the course, okay? It will rebound. Just let it be. Okay. Cardiogenic, okay? Most feared complication for CHF. Okay? Doesn't happen very often, but it does potentially happen. This is when the heart says, screw it, I'm done. Okay? I can't do this anymore. Okay? And then ultimately bad problems go from there. The LV just so compromised, it can't meet the metabolic needs. Your blood pressure, your mean arterial pressures in the 40s, 50s, okay? It just cannot perfuse, it can't keep up from that standpoint, okay? And then up to 40% of the left ventricle, okay? Huge MIs, myocarditis or irritation of the myocardium, the middle layer of the heart, volume issues, traumas, tension pneumos, cardiacs, and we'll get there, and then PEs as a factor. GIs, altered, cool, clammy skin, ashen. They may look cyanotic. Again, if they're black or people of color, look at the tongue from the cyanosis and all that stuff as a factor. And then they may or may not have pitting edema. Ask them, this is not the time that you're playing around on scene, okay? Looking around, weeding the garden and all that stuff. You're grabbing them and you're getting them on the road, okay? If it's you and an EMT partner, you're throwing them on the stretcher and you're putting them CPAP if necessary and you're calling for ALS intercepts, okay? Don't stay. And of course, looking at different medications and compliance. Exam, crackles, palpate, okay? They may have different, they could be tachydysrhythmias, they could be intermittent VTIV, VTAC. From that standpoint, they could be in blocks, AFib, just a whole range of stuff. So if they have bad pressures and they're in a lot of tachyarrhythmias, you feel the pulse and it's all erratic, they're having bad juju. Take care of the problem. If it's a PE, not much that we're going to do in the field, okay? If they're having an MI with us, not much that we're going to do in the field, okay? From that. If it's a volume problem, give fluids. That's why we need paramedics and all that stuff. If they're in, they're in shock because of the cardiogenic shock from a GI bleed, they need blood, those sort of things, okay? And then the whole aspect of CPAP versus BPM if they necessary for the respiratory side. And then for you guys, high flow diesel or gas. Okay. LVADs. Okay. We do have. There's one in Pickens County. I think there's two in Greenville County, if I can remember. I'm not sure about the remainder from that standpoint. Right? So they're out there. Okay. This is a HeartMate 3. This is the major one, the new of the ones that are kind of sort of out there. There's a couple of different brands and all that stuff, but the HeartMate by Abbott is the one that's out there. Okay, and some of them, the whole purpose of this is to augment the heart. Okay, so left ventricular assist device, LVAD. Okay. What it does is they have a tube from the left ventricle that goes down to a Worley motor. The Worley motor pushes up to the aorta and it circulates the blood. Okay, circulates. So it takes kind of sort of the left ventricle out of the picture. So they have a motor that's attached, that's inside of them. Okay, they have a line, it's called the drive line, that comes out attached to a controller, and they have some battery packs. Okay, some of this is a bridge to therapy, meaning that I'm getting this, and then I'm just waiting for a heart transplant. Okay, some of them, this is destination. Okay, this is their final destination. Right. This is what they're going to live with for the rest of their life because they can't get anything else. Some of them, again, on the bridge side they may have had a bad heart problem, but their heart is going to recover, and they just have to get them to that, and their hearts do recover.
Where does the drive line go through?
So through the peritoneum, through the abdomen. So actually, they'll drop down. Yeah. So the motor and all that stuff, usually sometimes they'll sit above the diaphragm, sometimes they'll sit below the diaphragm, but they'll drive the drive line through the diaphragm and then through the peritoneum. And then they have the controller outside. Right? For you guys, if you have a patient that has an LVAD, what do you need to make sure that you take with you? They need their extra controller. They have 2 batteries with them, okay? but they have a total of 4, usually up to 6, okay? And if they're going to be long stay, they actually have a battery pack or a charger, okay? So they have a go bag. So when you go pick up, they go, hey, I'm an LVAD. Hey, where's your where's your coordinator's number? Okay, your LVAD coordinator. And 2, where's your go bag? And look at the go bag, make sure that they have their extra controller and they have their extra batteries and their charger. And take them. Even if they're going just for, it's only going to be a couple hours, because unfortunately we had a patient that was a couple hour up in Ohio that turned into a snowstorm, that was stuck in a snowstorm. Yes, and the battery started chirping. Not good. Okay. Everyone started having pucker factors at that standpoint.
And where did this patient be transported?
Okay. They can actually, depending on what the problem is, they can go anywhere from that standpoint. Usually they need to go to their LVAD center if it's a true LVAD problem. In this area, GMH, for most patients that have LVADs, that's why I just teach my crews and all that stuff, is just take them to GMH. All right. But yes, if you came to Easley and they were there for a stub toe and they had an LVAD, okay, whatever. But if it's an LVAD problem, the sick LVADs need to go to GMH. Tamponade. All right. So different terminology, different perspectives of what a cardiac tamponade is. Some will actually, they have it as a fusion or a cardiac effusion or a pericardial fusion, and that's just a fluid around the heart. So a cardiac tamponade is when you actually have enough fluid around the heart that pushes on the heart, and the heart can't push blood. Okay, so you have an issue with the diastolic filling. When I decrease the filling of the ventricle, okay, what decreases? Okay, cardiac output equals the stroke volume. Okay, so when I decrease the ventricle during diastole, because outside pressure is pushing on the ventricle, it can't fill with blood. Okay, so I decrease preload to that area, correct. Okay, then that's by how I decrease my stroke volume. Okay, so I decrease preload, I decrease stroke volume, I decrease my cardiac output. So that is in essence what cardiac tamponade is in a nutshell. And there's a whole bunch of different reasons and all that stuff. You get shot in the chest, you get stabbed, okay? You have that. You have an aortic dissection, goes back and tears and blood gets poured in, right? End-stage renal disease. If you have cancers, all those things can cause pericardial effusions or blood into the pericardium, which in turn will cause a tamponade. The tamponade itself is just the impaired diastolic filling. Different reasons for it though. Aneurysms, okay? So an aneurysm is the arterial wall kind of sort of balloons out, okay? So on the veins, what's the big part of the vein? The externa, good job, the tunica externa. Okay, so the tunica externa is big. So that's why we don't really see a lot of aneurysms with veins. Okay, so you have a weak muscle, the tunica media, okay, and then the tunica externa, it's thin, so that will expand. So the tunica media kind of sort of tears open, or the muscle starts blowing out, and that's the aneurysm. Okay, and they can occur anywhere on the aorta. The ascending tract, which comes out of the heart, the descending, which is going down, or into the abdominal aorta.
What causes the inner 2 layers to get weak like that?
Usually disease, high blood pressure, the tears, those are the huge factors. Some conditions, we'll talk about Marfan syndrome, Ehlers-Danlos, and all that stuff. Okay. So weakened, okay, the artery, okay, it balloons out, and then unfortunately, if it gets bad enough, it bursts, Okay, and this we go from an aneurysm to the actual, that's the dissection side of it, or a ruptured aneurysm, what we'll call. So different factors, different place. Okay. So the inner layer, okay, you have the tunica intima, again the media. What happens is the intima kind of sort of tears open and it starts pushing the media out, okay? Because pushing and pushing and pushing, and if the tunica media in time, if it doesn't like it, it gets pushed out too much, right? That's where it actually will tear open and burst.
What determines, because I hear people have aneurysms, but there's not surgery done to
Yeah. Size, 4 centimeters is our typical, 3 to 4 centimeter from that standpoint, and it depends on where the factor is. Is it an ascending and descending versus abdominal? Usually anything under 3 centimeters is okay. Once you get to 4, it's bad, and then it's per decade of life. If you're 77, 80, from that standpoint. Still not good. Anyone know who this is? This gentleman? This is Jonathan Larson. This is back in the 90s, I think it was 90s. Have you ever heard of the Broadway play Rent? Okay. This is the gentleman that created Rent. Okay. Yeah. Yep. Yeah, he was in his 20s. He went to 3 different hospitals in that time period. It was start to be the opening show for Rent. He thought he was just having the flu-type symptoms. That's what he kept saying. EKGs, X-rays, and all that stuff. And then ultimately on the opening night of Rent, he was found dead from a aortic dissection. So if you look at him, what does he look like? Long faces. If you were to look at his thumb is actually goes beyond his hand. Okay. His ears are big. So this is Marfan syndrome. So he's Marfanoid. Okay. So Marfan syndrome, we know they're at risk of having aortic. So the same as Ehlers-Danlos syndrome, which is more in females. They're both collagen vascular diseases. Ehlers-Danlos? Yeah, so you're at a risk of having aortic stuff, okay? Individuals that had syphilis, okay? It's usually stage 2, stage 3, sort of secondary or tertiary syphilis. They're at risk, okay? You use cocaine, obesity, pregnancy, and of course trauma, okay? The most common though is just the unfortunate high blood pressure, chronic untreated high blood pressure.
Why does pregnancy?
It's the same thing as just the hormones and all that stuff. It decreases the risk, and then they're also at risk for pregnancy-induced hypertension. So,
John Ritter.
yeah, John Ritter. Yep, several years ago. Yep. So this is a type A and a type B, depending on the DeBakey classifications. Don't worry about that. This is just kind of sort of a type A where we think of it's the ascending aneurysm. Okay, this is the ones that we repair all the time. Right? The Bs, rarely do we. A lot of the Bs are medical management, keeping the blood pressure lows and all that stuff. And then they wash, and then of course it gets down to the abdomen, abdominal aneurysms. Okay, descending portion, it can be above the bifurcation. It could be the renal, so the renal arteries, the splenic artery. It kind of sort of varies. Okay, more common in men than women. Okay, they always say that men are the weaker sex. That's why men, we have more problems and all that stuff from that factor. Older patients, 60s to 70s, and then 2% of the population that have it.
They feel like they won't have a problem.
Yep.
You have to leave the earth.
Yep. Okay. Symptomatic. Okay. They're not really having. So you see this, their abdomen is pulsatile. It's bouncing up and down. You're like, that's not good, normal. Okay. From that standpoint. Okay. They can have pain and all that stuff. you can actually feel them, and they're going, hey, I feel like I want to poop, okay? And if they, again, once again, if they're looking bad and they feel like they want to have a poop, okay, what happened? They're going to die. Yep. Anxious, back pain, flank pain, tachycardic. They could actually, we had one guy that came in that was having a abdominal, he was dissecting. His brother was carrying him in on his back because he went from one hospital to another hospital and they said there was nothing wrong with him. So he actually loaded his brother on his back and was carrying him out. So it knocks off the nerves to the legs and all that stuff. And then they can't have enough, again, you don't have enough blood coming back, you lose your preload, so they pass out because of through hyperperfusion and all that stuff. Tamponade, if it does rupture, it has the ability, the potential of covering over and stopping the bleeding, so it might be intermittent. They could pass out, wake up, hey, nothing wrong. Hey, I passed out, I have abdominal pain, okay, from that standpoint. So syncope plus, okay, syncope plus lower abdominal pain is aortic abdominal, okay. Syncope plus, if you're a pregnant female, blood loss, you're ectopic pregnancy. Those are just those factors that play. Okay. Transport, okay. Avoid deep palpation. You don't want to push on it, okay. This is actually where some agencies are using ultrasound, and you can actually diagnose or see abdominal aneurysms with ultrasound and all that stuff. So we have the potential of teaching you guys as paramedics and all that stuff. If they're leaking, of course, mild hypertension, we will actually drop their blood pressure in the 70s. We keep their MAP into the 50s and 60s. Okay? We let their blood pressure, we'll call it permissive hypertension. Okay? Because if we increase the blood pressure too much, what happens? They tear even further. Okay? Or they bleed out. So we let the blood pressure drop down a little bit until we get them to the operating room. Okay? Hypertension, tachycardia, loss. And then, unfortunately, if they bleed too much, they die. Yep. Heart, brain, right? The two go together. They like each other. They love each other. They really do. Okay. Syncope. Okay. Syncope, by definition, is just the sudden loss of perfusion to the brain. Okay. What causes it? A whole bunch of different things. Okay. Vasovagal syncope, where you get startled, reflex, you don't get enough blood going to the brain, you pass out. Right? Did you have an arrhythmia? Right? Did you have a seizure? Again, from that standpoint. So a whole bunch of different factors into play. But it's anything that's a decrease, sudden decrease in cerebral perfusion. Cardiac output, okay, heart rate, stroke volume, we decrease our stroke volume, we decrease our cardiac output, we don't have our perfusion, we pass out. Okay. History of previous syncopes, and some people going, hey, I feel weak, I see spots, I feel like I want to throw up. And again, everyone wants to throw up. Just a normal thing. What were they doing? Okay. Are they stressed? Are they not stressed? Did you eat today? Are you diabetic? Are you pregnant? Could you be possibly pregnant? Okay. Did someone startle you? Those factors. Are you on blood pressure medications? Okay. Beta blockers and all that stuff. Do you have too much? Hey, I just had my beta blocker increase, and at the same time they increased my carvedilol, and now they put me on a water pill. Okay. Oh yeah, and I still have 2 or 3 nitro patches on. Okay. Yes. And then all that stuff. Right? What were they feeling beforehand? Always think about the other potentials, the intoxicated, embolisms, blood sugars, strokes. Do your due diligence. Okay. Go looking, figuring out. Anyone that passes out, always get a blood sugar. Okay. Anyone that passes out, do a quick neuro exam. Okay. Those sort of things. Yep. Okay. Of course, getting back to some more of the history side of it, duration, associated previous symptoms, and that's what Les was saying too, is on EC or EKGs and all that stuff. The American College of Emergency Physicians, which I'm a part of, for syncope, there's only one test that I'm required to get, EKG. That's it. Everything else is based upon how the patient looks. Now, if you're 60, 70, 80 on blood thinner and you passed out, you're getting a head scan. Okay, if you're diabetic, I'm going to get sugars. If you're at, end-stage renal disease, you're going to get. I'm going to look at your creatinine and all this. I mean, there's electrolytes. There's other things, but the EKG is the only thing that have to have. All right, home stretch. Okay, kiddos, geriatrics. All right. Yes, heart disease in kids. It does occur. Okay, very small. When we see them, we don't like it. Okay, these are the halos, high acuity, low occurrences. Okay, we don't like seeing this. Pediatrics. Okay, cardiac arrest is usually caused by something respiratory. They're choking on something. They get smothered. Okay, this is why babies. If you go into, if they're co-sleeping, yell at mom, yell at dad, all that stuff. At the same time, you're checking the fire alarm to make sure the batteries are working and going from there. Okay, teach, educate, educate, educate. Okay, do not co-sleep. How many times, unfortunately, I've seen and pronounced kids dead because of co-sleeping. Don't allow it. Okay. If they do have a heart problems, depending on age-wise, younger ones, congenital stuff. Older ones, it's usually more of a viral type infections, Kawasaki's disease, those sort of things. Some viral myocarditis. One of my cases that I teach all the time was a 5-year-old that had a viral illness and then went into cardiac arrest. So from that. Congenital versus acquired, are they born with it versus a viral or infectious? Cyanotic versus acyanotics. Okay. So the cyanotic, just by definition, they look blue. Okay, they're blue. All right, they have a right to left shunt. They're cyanotic. They may have aging-wise some clubbing of the fingers. The digital clubbing is because they don't get enough oxygen to the tips. Okay, you can actually have some individuals from different countries. They have undiagnosed congenital heart disease, make 7, 8, 9 years of age, and they have big club fingers and all that stuff. The syncope with the TET cells are squatting. So the tetralogy flows. They'll walk, and they feel a problem, and they squat down. Okay, and then they go back up. They're actually doing self-induced Valsalva. They're increasing their preload. Okay, that's what they're doing from that standpoint. So they're trying to, that's why they squat down. All right, kind of sort of the 5 major cyanotics is on the hand. And this is just an idea, okay, to go from there. So the truncus arteriosus, what it is, you have a single vessel, okay? The pulmonary trunk and the aorta, all this is one, all right? That's truncus arteriosus. From there, transposition of the great vessels. So instead of the pulmonary trunk on the right side and the aorta on the left side, they're reversed, okay? So the aorta, or the left ventricle goes to the pulmonary trunk and the right ventricle goes to the aorta. Not good, okay? They're born like that. So what they have to do is they actually do reversals and all that stuff, procedures. Tricuspid atresia. So the tricuspid valve is, they don't have a tricuspid valve. Okay, it's solid. They have to actually go and cut things out and go from there. Yep. Tetralogy of Fallot. There's actually 4 different pieces with that. They get a VSD, they get an overriding aorta. They have a, the pulmonic valve is stenosed. And then the right ventricle is enlarged, okay? So that's the drop with the tetralogy. In the total anomalous pulmonary return, basically the whole pulmonary system is all screwed up and they can't get blood back to the heart and from the pulmonary system and go from there. That's all.
Do they catch this stuff at birth?
Yeah. Usually the majority of them, if we have good prenatal care, they can actually on cardiac, they catch it beforehand and they know what's going on. Sometimes it's usually within the first week of life that they'll come into the emergency departments. Because all these, they're what they call ductal dependent. So the duct is what kind of sort of goes from, it's the last bypass of blood from the pulmonary side to the aorta. inside the fetus while they're still in the womb, because we don't want blood circulating to the lungs. So it's the last piece to stop blood going back to the lungs. So once that duct closes down, they can no longer get the blood circulating through. So then they have their problems. Yeah. So if we know that they're having problems, then we put them on medications to keep the duct open until they can get their procedures. One of the key things to ask is, how are the kids feeding? Are they feeding or not feeding? Are they sweating when they feed? From that standpoint. So you've got a sweating kid that's trying to feed is never a good sign. Or they're not taking their bottle at all. They're not eating. Cyanotics, PDAs, ACSDs, and the VSDs. The VSD, the ventral septal defect, is one of the most commons. Okay, again, the septum from that standpoint, okay, is an aortic septal defect, meaning between the atriums, versus the VSD, you have a hole inside the septal wall itself. So blood goes from the left ventricle to the right ventricle and then circulates out. Okay, it just pushes through. The patent ductus arteriosus, again, that's part between the aorta and the pulmonic. You have opening right in that area. That's what the ductus arteriosus is for. Most common, left to right shunt, growth retardation, murmurs, congenital heart, and they're at risk for infections and all that stuff. And again, all this is just an opening in the septal wall. Coarctation, the aorta itself gets narrowed down, it gets pinched down. Okay? And it can happen before the duct or after the duct. Okay? So depending on that factors. So this is the aspect of why when you have a newborn, okay, they pop out, you're doing the rub, stim, and all that stuff, the pulse actually put it on the right arm, the right hand. Okay? Because the right side, the blood vessels to the right side actually is before the coarc. So it will always get blood. Okay? So that's why the pulse ox always goes on the right hand for all newborns. They can have heart sounds, and then again, right hand for the pulse ox. Rheumatic heart disease, again, is this infection, Kawasaki's. We have electrical problem. Myocarditis is just an inflammation or infection of the myocardium. Do they get infections of the valves and all that stuff? Hypertrophic cardiomyopathy, Holcomb, the ventricle gets really big and hard and stiff, so it doesn't work properly. Dilated cardiomyopathy, pregnancy, kids, the left ventricle gets floppy, so it can't push the blood out. They get a stenosis of the valves. So there's a whole bunch of other acquired things. Do I expect you to know it? No, but there are from that standpoint. Geriatrics, okay? Just taking into considerations, old people, their systems don't work well, their blood vessels don't work well, they get coronary arteriosus, everything gets constricted down, their blood pressure goes up, medications that they're on, okay? They traditionally get one medication per decade of life, okay? So if they're 80, they should have no more than 8. Actually, I took care of a patient the other day who was 90, she had 1 medicine. Amazing, exactly. Yeah. All right, and it doesn't happen often from that standpoint. And then potential treatment options and go from there.
Say that again. You get 1 medication per
Decade of life. That's the theoretical. Yeah. Yeah. All right. So, finishing up here. Okay. Pump. All right, remember what the heart does. What is the heart supposed to do? It's supposed to do one thing only. It is to pump blood. Okay, pumps blood around so it can get oxygen and nutrients to the other parts. All right, cardiovascular, from the aspect of the pressure is the major thing. Heart, cardiac output, heart rate times stroke volume. Stroke volume is based upon
The amount of blood pumping out of the heart.
amount of blood pumping out of the heart. That's 70 mLs per, but it's based upon
Heart rate.
3 things.
Perfusion.
Oh, preload.
preload,
That.
Sir,
afterload, and
Contraction.
Contractility, good job. Okay. Again, our cardiac output at rest, we're approximately 5 liters because we do a heart rate of 70 and our stroke volume 70. So that's 4,900. Okay. This is why marathon runners have a heart rate in the 40s because they're actually pumping out, their stroke volume is actually better. They might have a stroke volume of 80 to 90, but that's why they don't need a heart rate of 40. They're very efficient, okay, from that standpoint. So again, but you're trying to circulate your 5 liters of blood. Cardiac conditions, already problems, okay, different medications or symptoms for your coronary syndrome and all that stuff for EMTs. Recognize, think of your atypical things. Older patients, diabetics, okay, they might not have pain, okay. Older patients might not have pain. Fatigue symptoms and all that stuff, okay. RALs, and all that stuff. Look at the whole totality of the patient, okay. Angina, okay, just the aspect of inadequate perfusion. You're not circulating the blood around. Remember your EKGs, getting all that stuff if they're thinking they're angina, going from there, okay. And if they're having chest pain, what's the only 2 treatments if they're having MI?
CPR.
No. If they're having a heart attack, aspirin and PCI, okay? Aspirin and PCI. Now, PCI, okay? Percutaneous intervention, okay? Okay? A heart center that can do that, okay? They got to go to the cath lab. Good job, okay? Different presentations from the ACS, okay? Think about, go from there, okay? Different complaint of pressure, pain, okay? Squeezing of my chest, squeezing and diaphoretic, 85 to 90%. They go somewhere, okay? You do not AMA them, okay? You do anything and everything to get them to go to the hospital. If not, you go and check on them an hour later, 2 hours later, 4 hours later, because they will probably be dead, okay? They'll go into cardiac arrest. And again, just the aspect they may not have. Secondary assessments, just kind of sort of figuring out, look at the medications, do your ample history, go down that pathway. Get your EKG. Hypoxia, short of breath if they need it, otherwise 94% is all that you need, okay, from that standpoint. Assist with nitroglycerin. It doesn't take care of it, it may just relieve the symptoms, okay? And don't use it as, I forgot to add that, don't use nitroglycerin as a means of diagnostic, okay? I've had patients with ACS take nitro, does nothing for them, okay? And I've had patients that have GI upsets that take nitro and their pain goes away, okay? Don't you let that determine from that standpoint, okay? Definitive treatments, of course, MIs, EKGs, nitro therapies, and go from there. Heart failure, recognize it, okay? Don't forget, all things that wheeze is not asthma and COPD. You guys have the capabilities, CPAP and all that stuff. You can outcome change. I've seen EMTs put a patient on a CPAP and the patient goes from your 20 to 30 minutes on a CPAP, they go from having to be intubated in the ICU to the floor. You guys have direct impacts. Pediatrics versus congenital versus acquired and all that stuff, and go from there, okay? Ask yourself why. Why are you here every day? Okay. Review. Get your path of phys. Questions? All right.
I'm gonna let y'all, since you got so much information.